in the newborn, encourage the mother to breastfeed early, or for bottle-fed infants, provide early and frequent feedings. As with any newborn, monitor the infant's temperature and provide warm blankets. Keep the baby warm by using warm blankets or a radiant heat warmer to prevent cold stress. Common complications of postpartum labor and delivery include fetal acidosis, oligohydramnios, fetal meconium aspiration, and fetal wasting. Neonatal complications include hypoglycemia, polycythemia, hyperbilirubinemia, and impaired thermoregulation. Now let's review some common delivery procedures. First, how will you assist a client who has an episiotomy? An episiotomy is a surgical incision of the perineum done to enlarge the vaginal outlet. Proponents of the episiotomy claim that it prevents perineal lacerations, minimizes stretching of the perineal muscles, and reduces the duration of the second stage of labor, and makes it easier to perform manipulations that facilitate the infant's birth. Opponents of the procedure say that the perineum might tear even with an episiotomy, and that pain and healing time are greater than that associated with lacerations. There are alternative measures for perineal management. They include preparing for birth using Kegel exercises and massage in the prenatal period using squatting or lateral positions during birth in order to allow for gradual stretching of the perineal tissues, and using warm compresses, manual support, and massage. Episiotomy is often done to deliver first-time mothers. If the baby is in an occiput posterior position, an episiotomy might make the delivery easier. When the fetus is large or the pushing stage is extended, an episiotomy can help ease the birth of the baby. Other rationales for episiotomy are fetal distress and forceps delivery. There are two types of episiotomy. A midline or medial episiotomy is an incision down from the vaginal opening toward the rectum. A mediolateral episiotomy is an incision made from about 30 degrees from the midline. A complication of midline episiotomy is the extension of the incision through the anal sphincter during delivery. When the rectal sphincter is torn during delivery, the client has a third-degree perineal laceration. When the sphincter and the anterior rectal wall are torn, the client has a fourth-degree perineal laceration. With a mediolateral episiotomy, however, the client usually loses more blood and the incision is more painful than a midline episiotomy. Potential complications of any episiotomy are pain, infection, and hematoma. Your role in episiotomy care includes applying cold to the perineum and episiotomy during the first 12 hours after birth. Apply cold packs for no longer than 30 minutes at a time, waiting 30 minutes to an hour between applications. Assess the incision by determining the RITA score of the episiotomy. That's an evaluation of redness, edema, ecchymosis, discharge, and approximation. Teach your client perineal care that promotes comfort and healing.
Interventions include the use of witch hazel pads or tucks on the episiotomy site, proper hygiene techniques such as gently patting the area dry from front to back, and changing perineal pads after every voiding and bowel movement. Also teach your client how to give herself comforting sitz baths and how to cleanse the episiotomy site. Prior to discharge, make sure the client knows the signs and symptoms of infection and when to expect healing, typically within 3 to 4 weeks after delivery. Caution her to avoid sexual intercourse until the episiotomy is completely healed.
How do you intervene after a forceps-assisted delivery? During the second stage of labor, it is sometimes helpful to facilitate delivery with obstetric forceps. They are intended to provide traction, rotation, or both to the fetal head to aid in the delivery. Forceps are similar to two large metal tongs separated and applied one at a time to each side of the fetal head. They have a locking mechanism designed to keep the blades from compressing the fetal skull. Forceps deliveries are classified according to the level and the position of the fetal head relative to the pelvic outlet. Low forceps control the head after it is crowning, that is, visible from the vaginal outlet. Mid forceps, rarely used, are applied when the fetal head is at 2+ station or higher. You will see the forceps used with prolonged labor, limited maternal reserves, maternal exhaustion, and maternal illness. Fetal indications for a forceps-assisted delivery are fetal distress, fetal malpresentation, and a large fetal head. Before the forceps can be applied, the following conditions must be met. The cervix must be fully dilated to avoid lacerations and hemorrhage. The client's bladder must be empty to maximize the space available. The presenting part must be engaged. The amniotic membranes must be ruptured, and the fetus must be able to negotiate the pelvis. In other words, there must be no signs of cephalopelvic disproportion. Your interventions include explaining the need for the procedure to the client and her partner. Make sure the client has voided or catheterize her if necessary. Take the fetal heart rate before the application of the forceps. Once the forceps are in place, monitor contractions as the traction is applied. After delivery, assess the client for vaginal and cervical lacerations by looking for a trickle of blood different from the lochia, and observe for urine retention from the bladder injury. Also, assess the infant for bruising, abrasions, facial palsy, and subdural hematoma, documenting the size and location in the infant's medical record. Another option for facilitating delivery in some circumstances is vacuum extraction, which is attaching a cup connected to a suction to the fetal head to exert negative pressure and downward and outward traction. During this type of delivery, urge the client to continue to push with contractions. Vacuum extraction is used to shorten the second stage of labor in the event of dystocia, in cases of cardiac decompensation, and in cases of fetal distress. Before vacuum extraction can be used, the following conditions must be met. It must be a vertex presentation. There must be no signs of cephalopelvic disproportion, and the amniotic membranes must have ruptured. After delivery, the newborn must be watched for bleeding under the scalp, called cephalohematoma, cerebral irritation as evidenced by poor suck-swallow reflex and lethargy, and jaundice as bruising or hematomas resolve. Potential maternal complications of vacuum-assisted delivery are vaginal and rectal lacerations. Neonatal complications include